It's visible, right?
Yes, ma'am. Your presentation is visible.
Yeah. So very good afternoon to everybody. I'm here to talk once again about the chevron incision in MSICS because I have found this incision to be so useful in reducing astigmatism. As we know, the need of the hour of the patient is uncorrected vision. So this is one of our typical patients who present late, a 78-year-old gentleman with a hypermature cataract. You'll be able to see the calcified capsule later. The chevron incision, I started with the frown more than 20 years ago. Now I've been teaching incisions and SICS to all our postgraduate students. I've been a postgraduate teacher for a very long time. And in our research publications and ongoing work in astigmatism, the latest was published in the special IGO issue in 2022, in which our patients with chevron, in my patients with chevron incision, had the average astigmatism of 0.32 diopters plus minus 0.27 diopters, which is again very encouraging to us. So this is a typical patient. This is the kind of nucleus that we get. And this surgery definitely requires SICS. I would, this is not a surgery of compromise. I would definitely say this is the surgery of choice. It is not compulsion, not compromise. I'm doing this by choice. So this is another patient. I think it's very important to measure the apex of the incision from the limbus, because I have seen many postgraduate students who tell me that my incision is also 1.5 to 2 millimeters from the limbus, but when you measure it and when you put the caliper to the test, we find they're 0.5 millimeters from the limbus, because it is much easier to go there. It may be easier at the time of surgery, but lifelong for the patient, it is better the further you are from the cornea. As you can see, these are all mature cataracts, sort of white cataracts, in which I find that the forceps through the tunnel is much easier to use for the rhexis and much quicker. So again, I'll show you one more. So this is another patient, hypertension. As has been discussed so many times, we cannot over-cauterize, we cannot under-cauterize. We cannot go too deep in the incision, we cannot go too superficial. 50 to 75, you should be able to see the crescent blade throughout the tunnel. The tunnel should be adequately wide. That means the corneal part also has to be wide. And try to stain the anterior capsule wherever possible, because it makes it much easier in any patient. Again, I use the forceps for the CCC because the time is so limited. So I'm just showing a little bit. And the hydrodissection is very useful. Do it just beneath the capsule so that you get the maximum bulk of the nucleus out. And after that, use the visco. As you can see, this is an indigenous intraocular lens, which is, so this is another patient with advanced ISC with diabetes mellitus. This is, I'm showing a close-up of the incision. I've made a wider chevron. And of course, everything measured with the caliper, you can see the crescent blade clearly through this measurement, 2 millimeters from the limbus. And here we make the entry with the keratome. These are all disposable, inexpensive instruments. So in our country, most of our patients who come to us in the government hospital have advanced cataracts and a lot of comorbidities. Again, CCC is being done with the rhexis forceps. And the irrigation apps. After this, a foldable indigenous intraocular lens, which costs 650 rupees to the patient, has been implanted. In a young patient, this I'd just like to highlight that in this patient, the patient was 40 years old, a young lady who had very high expectations and came through somebody to me. So the total width, the span of the incision is 6.5. And actually, when I measured it, it was 2.5 millimeters away from the limbus. She had zero induced astigmatism. So in a younger patient, when the nucleus is not hard, you can manage to, or you can afford to go further. My whole crescent was used at the periphery. This is the incision that was made, 4 millimeter wide, 6.5 millimeter between the two ends of the chevron incision in this lady. So the mean surgically induced astigmatism is 0.32 plus minus 0.27 diopters. As you know, the post-operative results are very important. These are some of the pictures of these patients post-operatively. And these were all happy patients. Somebody asked me, do you get astigmatic surprises? So in general, we do not. Our expectations always are like this on the one-to-one thing, but the experience is more like this. This is an actual patient, the picture of our OPD, which was published in the paper on the lower right side. This is the volume that we have, which is, we are very blessed to have a large number of patients, and we are still learning. I'm still learning to provide quality to quantity. The chevron works very well. I'm trying to teach it, but at least I'm making the PGs do the frown incision to begin with and not the straight incision as far as possible. Thank you so much for having me here. It's an incredible opportunity. Thank you, Dr. Sahu sir, Dr. Boramani sir, Dr. Aarti, Dr. Namrata Sharma, Dr. Lalit Verma, and AIS. Thank you so much.